Okay, so the question is really if you have a pressure wound on your foot, right? And I'm not going to prepare for this. I'm in the middle of cleaning up the basement. But if you have a pressure wound on the foot, does it make sense to treat venous disease to get the wound to heal? And then I said something to the effect of, please make sure you address the arteries first. And then somebody then put back and said, well, could you explain us why? What's my rationale, right? So, Black with Vascular, once again, trying to educate people and keep people on the right path. The basics is this. Wounds can develop from a variety of different reasons. I always tell, whenever I have a patient with a wound on the foot, I always say, name 8 things or 10 things that can make a wound for. Because these wounds are always multifactorial in terms of their reason for why they formed. Not always multifactorial, but every single thing in life is multifactorial. There's nothing that's just black or white. It's never that simple. So the question is now, what percentage of it is due to this thing or what percentage is due to another thing? So let me give you some options of things that can cause a foot wound, and I see commonly. Number 1, an artery that's blocked. Smokers, diabetics, people with hypercholesterolemia, hypertension, elderly patients, people who have had stents or bypasses in their legs, people who have the same group of people who have heart attacks and strokes and everything because of blockages in the arteries can have lack of blood flow going to their foot, and thus you can have a foot wound problem. Think of it like a heart attack of the foot, but it's not exactly not that. But the point is that if you cut down the amount of blood flow sequentially over time by occluding or blocking each vessel over time with disease and junk and plaque and all this cholesterol and stuff, then what you end up with is a situation where you have a wound, and normally a wound might heal in 2 weeks, but now you have a wound, you get cut and it doesn't heal in 2 weeks, it takes 3 weeks. Then it gets, as your disease process gets worse and your amount of pressure, blood pressure that's actually getting into your toes or into the area where the wound is, gets worse and worse, you can ultimately get to a point where you have almost 6 weeks, 8 weeks to take to heal a wound, or the worst case scenario, a wound that forms that does not heal. My God, why is it that children walk around as if they're like, I don't understand it. Why can't you just walk normally? Anyway, so I don't know if you guys can hear that, but so arteries is a big problem. And your problem, and if you had a problem that was due to the arteries, you fix the arteries. You do a bypass, you do a stent, you check at least the blood pressure in the top of the foot and the side of the foot, feel for a pulse, make sure the pulse is present and palpable with the fingertips, not with the machine, the Doppler machine, to hear the whoosh, whoosh, whoosh. So not that. The actual feel with your fingers. That means your pressure is above 60 millimeters mercury. Most physicians can feel that pulse. That means you have already enough blood flow. If you feel a pulse, arteries are not the problem. Let's go somewhere else. Okay. So veins. Let's talk about veins. The exact blood can go into the foot through arteries. Blood returns through veins, little veins that run back up. If the veins, let's say the arteries are perfectly fine, but the veins are not fine. If the veins are not fine, then what happens is when you stand up, your valves, everybody usually has one-way valves in their veins that bring the blood sequentially up to back to the heart. You don't have a heart in your foot. Your calf muscle kind of squeezes like a bellows a little bit. Let me just see if I can find that animation. Calf muscle bellows animation real quick. This is one of them. There's a good one that I've seen where somebody describes it to the old-fashioned pump, but let me just flip this around. Look online and you can see these ideas of the calf muscle pump, where the muscle itself is actually squeezing and pushing blood up the valve. If it's pushing up the one-way valve, if it's squeezing the vein, it tries to push down and up. But if the valve is functional, then the blood has to go up because these are one-way valves pointing upward, right? If the valves are broken, then you can imagine blood can go in any direction it needs to go to at all. Because if you squeeze it, it'll just go wherever it wants to go. So the calf muscle pump is an excellent way to return blood to the heart. And the reason why we tell patients with vein disease to walk a lot is because by walking, you actually activate this pump and have it squeeze. All right. So if you have vein disease and you have a high pressure in your leg because your ceiling and your floor of each valve is not functioning, and every time you stand up and you're standing around, it's literally like you just have a huge leg with just no one-way valves. Everything just falls to the bottom and stretches out at the bottom. Then your skin is stretching at the bottom. Your calf is stretching. Your ankle is stretching. And in fact, it's probably not lost on patients on this Facebook forum page that most of the people who have ulcers, who are vein disease patients, where did you form your ulcer? Most people have their ulcers in what's called the medial malleolus. And that's kind of almost like the sine qua non, the way to tell how, almost every single time a patient has a venous ulcer, that is a sign of vein disease. Look at that. That person has some venous disease. Yes, it could be a spider bite. Yes, it could be something else. It can always be something else. It's medicine. It's never easy. But if you see a person with a venous ulcer on the medial malleolus, something like this, that is, you have to think that is a medial malleolus ulcer. You got to think that's vein disease. And the reason why is because the saphenous vein runs on the medial malleolus. So imagine the highest pressure is usually right there on that medial instep portion of your ankle. It's not going to be in your calf. It's not going to be with your thigh usually because the higher pressure is at the ankle. So that's why that area gets darkened first. That's why the iron deposits are highest there. And that's why long term, what happens next is that you end up having an ulcer there. So if you had vein disease and you had no arterial disease, why would you go and treat the arteries? Why would you actually treat the arteries first? You wouldn't. You would treat the veins. But, let's say you had vein disease and you also had arterial disease. Which one would you treat first? There comes the critical question. How do you treat artery disease? Well, you treat artery disease by telling the patients to eat a healthy diet and walk and exercise, and some of the same things that work for vein disease. In fact, that stuff works for everything in medicine. If you guys were all to just eat a healthy diet, walk, exercise, and don't smoke, don't drink, every single physician would be out of a job. 9 out of 10 hospitals would close. They would just become birthing centers for like healthy babies being born. And maybe a cancer center would remain, but even the cancer centers would drop significantly. But literally all of medicine is funded by poor diet, poor activity, and smoking and alcohol. Those 4 things, as well as trauma like car accidents and stuff, that's literally all of what supports the American healthcare system and the healthcare system of all the countries of the world, really. So with that said, I'm not going to tell people not to eat their chips and popcorn. I just had some myself. I am drinking some kombucha. That's good for you. Relatively low calorie. So arteries and veins, you have both. We have both. We now have a situation with a patient with both artery and vein disease. What do we do? Well, some might say, go get a stent, minimal invasive, super easy, just bing, 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 bang, boom, you're in and out, Day hospital, everybody loves that. The Americans love the one time, just quick and easy, fix it all, Well, there's an alternative to that. Let's say you get a stent, the stent works for 5 years, you're on aspirin and Plavix, you're doing a good job, but eventually the stent fails. For whatever reason. Stent works for even 10 years, who knows? The disease comes back, you end up with more artery disease. Now, for whatever reason, you've decided not to manage or even look into your vein disease, right? So you still have your veins, your artery stents have failed, a new surgeon comes by and stents a new area or puts a stent inside of that stent or who knows what. Well, each subsequent operation that you do gives what I call, and actually this is what Dr. Graver used to try to explain this to me, that basically there comes a point in everything in life where you can keep investing, right? And the more you invest, usually you get more and more you get more returns. Well, at some point you start investing more and more and you start not getting any more, right? So the law of diminishing returns shows this in healthcare as well as in finances. So you put a short stint in, you get a good result for a couple of years. You know, to go for a bigger procedure, you get a better result maybe. You might even end up getting a bypass surgery, or in which case, we'll talk about that in a second. You bypass not from A to B, which is 5 centimeters away from each other. You now had a stent placed in the artery, but now you have to bypass from a little bit upstream of that because this part is clogged when the stent failed, and that part's clogged and a few branches have popped off and have died. And now you have to go from A all the way around this long segment. Now, if that bypass fails, you have to go above that bypass and jump from even higher up and go even further down. So you can imagine over time you're getting longer and longer bypasses or stents, and over time you're moving yourself towards cutting the leg off, or the limb, or whatever it is. As you do longer and longer bypasses with worse and worse conduit, whether the stent becomes longer or the bypass graft is not the ideal graft, the ideal tube that you're sewing from A to B, then these things last less and less. So imagine now you go for a 6-hour surgery. You know, your grandfather or your grandmother goes for a 6-year surgery. This is 6-hour surgery, and the surgeon had to take 2 pieces of vein, one from the right leg, one from the left leg. Why did they have to take 2 pieces of vein? Oh, because when they were back in their 40s, they burned or removed that vein because they had varicose vein disease. Okay, all right, so that's okay though, because it was appropriate to treat it. Not saying that you shouldn't do it, but in life there is no free lunch here, guys, right? You have to just be aware that every action has a consequence and has a downstream reaction to it. So even if you have taken the veins appropriately 30 years ago, it doesn't change the fact that now you're fast forwarded, grandpa continued to smoke, and now he has an ulcer in his wound. We think it's a vein ulcer, but it actually has an arterial component to it. He needs a bypass surgery because he cannot get a stent because he's been stented 6 times already or 4 times already. And now what the surgeon is doing is splicing, connecting 2 separate pieces of vein together to go from his groin all the way down to his ankle. Now what does that mean? That bypass is not going to last as long as a natural vein. Worse, if the vein is completely gone, if you've burned all the veins and treated every single saphenous vein that's in there, and all the veins are no longer available to be used as a conduit, as a tube to connect around the blockage. Now you're talking about using a piece of plastic like a prosthetic or a cadaver vein. These do not last as long. If you don't believe me, look up the best CLI trial, which Matt Menard, when I was at Brigham, he was running this trial. He spent every day working on this trial, and it was a big NIH study. And essentially, I'll show you a nice picture. Oh, there we go. Here's Matt Menard right here. There he is in the middle with the glasses looking all studious. He's the only man there with hair on his head. Kenny Rosenfield is in there, and Alec Farber. These are all brilliant surgeons who worked, as well as interventionalists, who worked together to develop this trial called the Best CLI. And Best CLI showed us. I'm sorry, give me 1 second. Let me just pull that out. I want to show you guys because this is good information. Best CLI trial, I guess the summary of it all, the Cliff Notes version, is that if you're going to do a bypass for a patient who has an ulcer that's not healing, or a wound that's not healing, whether it's a pressure ulcer with some lack of arterial flow because of a blockage, or a vein ulcer with some lack of arterial flow because of a blockage, if you need to do arterial connections from A to B, you need to use a good single segment, one single piece of saphenous vein, ideally from the same leg, and that is what gives the best result, irregardless of the age. Doesn't matter if they're 90 years old or 80 years old. When they looked at all these people across America, this trial is brand new. It just came out. This is brand new stuff within the last 2 years, right? A single segment saphenous vein. So you'll hear people talking about stents and atherectomy and all these fancy minimal invasive approaches to trying to reopen blockages. They're not there yet. The single segment old-fashioned saphenous vein with a big cut, fillet the leg open, take the vein out, or cut the vein, the leg in segments, and take that vein out and plug it in, is still the best. Yes. Hard work and all that investment, the investment of the patient to sit there in the operating room and go take the risk on, the surgeon to bend over the table for the next 4 to 6 hours trying to harvest and tie up that branch and have a nice, perfect bypass. At the end of the day, it is the best still. So why would you burn that saphenous vein, glue that saphenous vein, varithena that saphenous vein, and have it all sclerosed and scarred up and not even functional, and then not even be sure if you have an artery issue? This issue is quite important, and I think that's why I'm posting it, because I think this was a simple situation where where the person is just asking on Facebook, like, what's my rationale behind treating the arteries first, or even investigating the arteries first? Well, this is the rationale. The rationale is the guy I had in Syracuse a few years ago who had artery disease. I was following him for 2.5 years, and he went to Florida. I'm not going to say that Florida is a bad state or anything, but Florida man found this guy, and when he came back from Florida in May or April, I think it was, every freaking vein had been treated. He had all his arterial disease, and I was working on him for, putting minimally invasive. I was planning for, I wasn't even planning for a surgery. I was just planning to leave his veins alone, and his wounds he wasn't having, I think maybe he had some toe wounds or something, but it was clearly artery wounds, and I had done some angioplasty and maybe a small stent or something, and the plan was that in the future he would have this vein for bypass. Even though it was varicose, it wasn't a huge vein. It was a suitable vein that could have been used for a good bypass. Well, every single vein was burned. And I'm thinking to myself, like, these people did not even check to see if this guy had a heart problem, like angina, or if he's still a smoker. He's still a smoker, so he's still knocking off his arteries one by one, and yet you go ahead and just treat everything. I don't know, man. America, my country, but still, we have to do better, guys. We gotta do better. So, pressure ulcers are caused by pressure. I'll give you an example of a common thing I saw this last week, and these can actually end up getting so bad that ultimately you can end up losing your foot. But imagine you're a patient who had bad diabetes and severe neuropathy. You can't feel your legs, you can't feel your feet, and this is what it looks like. This is what you have on the bottom of your foot, something like that. You see that wound? So you have these ulcers right on the head of your, almost like what you call a bunion. It's the malleolus. It's the head of the malleolus, right? The head of the not malleolus, head of the metatarsal bone. So every bone has is like a little chicken bone, right? You got little bulges on both sides. The metatarsal head is the bulge that connects with the toes, that connects to that with the digits that connect here. So that metatarsal head is that bony protuberance is where you're actually putting pressure on right there. And that's why when you walk around and you can't feel your foot, you might be standing for an hour and not readjusting and leaning over here or leaning back here. And so you don't realize that you're feeling uncomfortable And so you just keep standing, and eventually an ulcer forms. And that's why diabetic people have Charcot foot. Now this person, you see this thickened white rind around it? That callus is a sign that when you put your finger on top of this person's foot, or sometimes on the side there, you will feel a palpable pulse usually. These people don't have a problem with the big arteries. These are micro blood vessel issues with diabetes, too small to be operated on. And this person, yes, this could happen in the situation of a patient with vein disease as well as artery disease. But why would you go ahead and just start treating arteries and veins when the first thing you need to do is get this person off their feet, get them to a podiatrist or a wound care center, have them fitted for new types of shoes, right? So the long and short of it is, multiple things can cause wound healing. Infections can cause wound healing. If that's the major source, treat the infection first. And not that you have to treat everything sequentially, but you could target most of your therapy on the infection treatment, right? Take the antibiotics, clean the wound up, drain the pus. If the wound is caused by immune problems, maybe the person is on chronic steroids for rheumatoid arthritis or ulcerative colitis, or they're one of these taking these new medications that you see every single day on TV. Anything that ends with the name blank imab, IMAB. It's always like, make up a name, Luvia, right? It's a new thing where every single drug that they make, these are tyrosine kinase inhibitors usually that were initially developed for like cancer, but now they're using them, they're finding a role and to specifically make specific ones to target each disease process. Now these are wonderful drugs for the people who have the immune problem, rheumatoid arthritis, ulcerative colitis, who knows what. But if you are developing a Charcot foot wound or a immune ulcer, or you have a wound somewhere that is due to mostly because you're on this medication, or this medication is tipping the scale between wound healing and wound formation, then maybe you might have to come off that medication for a while. Talk to your doctors and figure it out, because you can't just start treating veins only and assuming that will be the only solution. If the veins are, let's say you have a 2 millimeter saphenous vein with some reflux, is that really the main cause of your problem? Is that really, if you have two valves that are not functioning and there's a little reflux, yes, of course we could burn the vein. Yes, it might be just at the borderline where it's covered by insurance, but do you really need treatment? And is that really the thing that we should be looking at when you're going to continue taking triple doses of this steroids and immune suppressing agent, as well as other things, and all of your problems started when you started these new drugs. While your immune problem were solved, this new wound has developed, or the wounds that you had have now starting to worsen. So my point is that, like, it's not so easy to just say you can do one or the other. Let me show you one last thing, cause wound healing. I'm going to give you a list of things. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Here we go, 10. So we talked about arteries, we talked about veins, we talked about pressure and neuropathy. The other things that we should talk about is wound care. If you have a wound and you're not caring for it properly, if it needs to be kept moist, it needs to be kept moist, not soaking wet and not dry and scaling out. If it needs to be kept dry, some wounds need to be kept dry, you need to actually form a scab, then you can't be covering it with a bandage and leaving it moist all night, and then the skin becomes macerated. So you need to talk to your wound care specialist, you need to talk to a physician, you need to talk to your doctor. I'm not here to be your doctor, I'm just your internet doctor. I am here to teach you guys how to protect yourselves and how to start empowering you to actually start taking care of yourself. I'm not selling you any smoke and mirrors. I'm selling you the reality of life. What else? Nutrition. There it is on the list. Nutritional status. So patients with alcoholism pretty much don't eat very well because they get so much calories already from the beer, they don't really feel hungry. If your protein intake is not adequate, you won't heal wounds properly. If you're not getting all your vitamins and supplements, then you won't heal wounds properly. So you need a lot of things, and you can look up the list of them and try to figure it out on your own. But you got to take this into imagine yourself, if you have a wound that's been chronic, you can heal it on your own. You don't need any doctors. You just need to look up every single part of it and become a scientist of that wound and give it time. And most of the time, you can get it to heal on your own. There is times when you can't. There's times when you need the doctor, if it's the artery or whatever. But you can at least start now. If you're smoking, maybe quit. Maybe quit and pick it back up when you're 99 years old. But don't smoke right now because it's not good for you. It's causing you to develop a wound. So you got to take a break from all these things. We talked about medications. We talked about infection. We talked about blood supply. I'm sure there is more than this too. But yeah, I mean, I guess scale tip. Let's see if I can find a nice image of. All right. Yes, this is beautiful. So this is my final image for you guys for the day. This is a scale, and this is wound healing. If your varicose veins are this little one, don't take off this one first. Maybe take off the pressure, which is this big guy down here, or make sure you investigate and make sure the arteries are not the problem first. If you investigate and the arteries are this one, then sure, by all means, if this is the vein, go ahead and treat the vein, right? But think carefully, because if two of these are there and you actually have to use the vein maybe to treat the arteries, then think carefully before you start treating the arteries. This is the one time where you cannot take back what you've already done. If you treat a vein, you do not have the vein available to do a bypass surgery. And the bypass surgery is the best way to treat the arteries. So please, 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 my final word, investigate your arteries before you treat your veins. Good luck, guys. I'm gonna go paint this door behind me, which is the sauna that I'm trying to build. It's been a labor in love, still not happening. Hopefully by the end of this year.